All right, so now, welcome back. We're going to do this fourth section, or the fourth module, where we're going to talk about what are our priorities, how we manipulate the vent, both the patient's vent, and our vent, and really we're going to talk about this give and take between all the different priorities we have. Okay, my fellowship director said, mechanical ventilation is always like robbing Peter to pay Paul. All right, you always get one thing and you lose one thing, and you got to decide, what your priorities for the pathophysiology are in front of you. And this will become, this is, in dealing with COVID-19, we have to think what our priorities are. And I think, unlike other diseases, unlike traditional ARDS, where we sort of have some consensus, that what our priorities are based on, the ARDSNet trials and the trials for the last 20 years, everything in COVID is a little bit confusing. Okay, but just to remind you, okay, we went through the normal scalars, so the normal scalars, and you can look at event and you can see if something's off. All right, you can also look at kind of event and through the equation of motion, which is the second thing we want to start to understand about the pulmonary mechanics of the patient in front of you. And so especially when speaking of COVID and we talk about these high compliance, low compliance states, high elastance, low elastance states, you can start to understand what that means. You understand that if it doesn't require as much pressure to achieve a certain volume, then the patient has a fairly high compliance. And if it requires a whole ton of pressure to achieve a certain volume, then they have a low compliance. And so, as we start to separate these two phenotypes of COVID-19, although one could argue that the second phenotype H may in fact be mostly due to lung injury, whether we can avoid it or not. Many times I presume that we need a PaO2 that's viable with life, and so until we have another answer, I'm not sure that we can avoid lung injury. In any case, so the normal scalars, about pulmonary mechanics. Now if your patient's awake, you can start to look and think about what the patient-ventilator interaction, what's going on. And now you're at the final section where you want to decide what to do. And to do that, you have to talk about your priorities. And there are a lot of debates about this. And this is sort of the juicy stuff where intensivists, argue about what is or should not be the priorities. Okay? Primarily what I'm going to talk about are the drugs that we use, okay? That is to say, there are lots of different priorities, so I can say volume, pressure, pH, neurostatus, sleep-wake cycle, movement. Patients, that are obviously very sedated cannot move. And typically we like to get them in chairs, and you do all this as pulmonary rehab and to keep them, themselves from being stiff. Now this has been taken, out of our arsenal a lot because of, the concern over the contagion of COVID-19. But ideally many places are walking people on ventilators. And that is because you want to reanimate them after they go through whatever they've gone through, and you want to keep them as functional as possible. And so your priority in that sense, so long as they can do it, is to try to keep them moving, decrease any chance of blood clots, keep their muscles working, and everything like that. So you have a lot of competing things, and you have to decide what you believe. You could also say, patient comfort, and that's also another one, right? So ideally, you'd give no one any sedation, right? They would just be on the vent, and you don't have to worry about causing, building up, opiate tolerance or anything like that. But then what we don't want to do is sacrifice patient comfort. All right, so we typically have to give something. For some reason, some patients are very can be more comfortable on vents than others. So, but these are all your priorities, all right? And so we'll talk about the fact that what happens in ARDS a lot, in a low compliance state, is that you have, you know, you generally have a low compliance state, so you have a high elastance, right? So, you know, it tends to require, let's put some PEEP in there, I always forget that, you know. You know, so typically, if you look at vents of patients that have a low compliance, again, pressure equals volume over compliance, so your compliance is low, you're trying to achieve volumes, you know, 4 to 8 cc's, and so you require high pressure. So, you know, patients that are in real ARDS, you'll notice that their pressure is higher. That is to say that it requires more pressure to push these lungs open that have high elastic forces or low compliance. And, you know, you'll see that in the same notion, they tend often not to air trap, all right? You know, again, this is a measure of what, you know, Dr. Habashi calls the, you know, a viscoelastic nature of the lung, which is to say that, you know, whereas patients, we didn't talk about this, like an expiratory dysynchrony, you know, but, you know, right here, if your expiration doesn't go down to 0, this is what we call air trapping, all right? If your flow doesn't go down to 0 at the end of inspiration, this typically is not a major problem in low compliance states. Because they have high elastance, and boom, it goes down. You know, so you know, you're requiring high pressures to achieve low volumes, and so what is, you know, but generally, especially if you work at an ARDSNet place, you know, volume. What is the highest priority that people hold? Tends to be volume, especially in medical ICUs. And you'll start to see when you think about priorities why, when you walk around to different types of units, surgical ICUs, medical ICUs, cardiothoracic ICUs, you'll start to see that things are run slightly differently. Neuro ICUs, things are run slightly differently because there are different priorities for the predominant pathologies. In medical ICUs that deal with ARDS on a regular, continual basis, volume typically reigns supreme, and that's because of all the studies, all right? But what do you sacrifice with volume, all right? So remember, if you're going low on volume, why not just run everyone at 200 cc's? You know, if you say volume is lower, well, you have a minute ventilation, you know, and that's always something to keep track of. But if you have you know, if you're breathing, you know, 10 times a minute, 200 cc's, you know, you have 2 liters minute ventilation. That's extremely low, all right? You know, a regular person's minute ventilation is 5, all right? This is also something very important to look at because it can tell you something about the nature of the underlying disease, whatever it is, right? So patients that are sick, patients that are septic, patients that have fevers, they all have increased metabolic activity, and their minute ventilations tend to be much higher. If you have a minute ventilation, you see a patient is, you know, they're riding a minute ventilation of 6 and their gas has been fine, all of a sudden you come in and you know, their minute ventilation is 12 because they're triggering the vent, then it makes you worry that something is going on. Or on the flip side, if they're paralyzed and their minute ventilation was 8, and today it's also 8, but now they're a whole lot more acidotic, you might be worried that they have a higher metabolic rate, and so they're producing more CO2 and they're not getting it out because their minute ventilation is the same. In any case, so going back to this, you know, so again, you know, volume is supreme. Why don't we do 200? Well, your minute ventilation is low. What's going to happen? You know, your minute ventilation is going to go down, and your pH is going to be very low. You know, let's say a pH of 6.9. You know, and now this is another priority. It depends on what you decide your priorities are. There are people that do not worry. Some people have different levels of tolerance with hypercarbia and low pHs. You know, I know some very brilliant people who tend not to worry about this. You know, there have been some studies of rowers that, and after meets, you know, they grab their pH and their pH is 6.9 and their proteins aren't denaturing and so forth. Now, these are younger, healthier people that aren't in a state of a major illness. So but you have to decide what your tolerance is. For example, so if I say I'm not going to tolerate anything below 7.2, then you have to manipulate the vent accordingly. This is presuming now in these ARDS patients that the patient is either heavily sedated or paralyzed, and so you're predominantly in control of everything. But so you have to increase the minute ventilation. So how do you do that? Well, you can increase the respiratory rate, right? Or you can increase the tidal volume. All right. So often what will be done in a medical ICU is we still want to keep their tidal volume 4 to 6. Maybe someone will go up to 6, and then because they are don't have highly compliant lungs, you'll tend to increase the respiratory rate as long as they're not air trapping. All right, this is what in a lot of medical ICUs you do. Now there are some people who believe that it is not just the static inflation, which is to say, if I let's say I just hold you up here at a super high pressure. There are many people that argue, and this is really where APRV comes in, is many people are concerned that it's actually the dynamic inflation which is causing the lung injury. And this is a good question to ask, intensivists, is what do you believe is more responsible for injury, static inflation or dynamic inflation, which is to say, is it worse to hold a high pressure, steady for a long time, or a lower pressure and just keep pushing it in and out? And I'll tell you, there are disagreements on this. I'm not going to say what I subscribe to now. I just want you to learn this. So, but if you believe, for example, that dynamic inflation, is the problem, you may be more willing to increase the tidal volume above 4 to 6 to decrease the respiratory rate. But these are all just priorities and different viewpoints of what you want to do. So, this is at this point is when you make clinical decisions. One of the biggest decisions being made is whether we are going to sedate these patients. Sedation leads again to a loss of sleep-wake cycle. The patient is out of it. They're not neurointact. It's harder to move them. It's harder to do everything. In general, it's not good for them. So you have to decide, if a patient wants to take a higher volume, what is your priority at this point? I will tell you, for example, in the ER, I tend to keep people very sedated because my priority is in that direction. In an ER, we do not have 1 to 2 nursing. Sometimes the trauma comes in and the patients are forced to, not have someone around them for, a good bit of time. And so in my opinion, in an ER where we are intubating patients that tend to be in an acute stage of illness, whether septic or whatever it is, I am willing to sacrifice their sleep-wake cycle and all that stuff and their immobility in order to achieve my priority of making sure there's no dysynchrony and they don't pull out the tube and things in the ER in the vicinity I am working in are under control. And so, when I tell residents to sedate someone and keep them heavily sedated, that is in other words me saying, my priority right now is that our patients do not self-extubate, are not dysynchronous, the patient is generally comfortable, doesn't feel pain, and I'm willing to sacrifice all those other things, movement, sleep-wake cycle, possibly increased risk of delirium and so forth. And so these are just, these are just priorities that have to be determined. And so when we talk about, COVID-19, the question is, what are our priorities? And now we're seeing 2 different types of patients, which Gattinoni describes, as type L and type H. It's a little confusing, but just remember that he's referring to elastance. So they're low elastance, high compliance, low lung weight, that's how he describes it, and high elastance, high lung weight. All right. The question I have personally is what causes the transition between the two. All right. Is this a natural evolution or is this due to lung injury? I'm leaning strongly towards the latter. That is not to say that we have any answer to this. we need a PaO2 which is viable for life, all right? So if everything we've done, high flow with a non-rebreather, everything we've done is not achieving this, right now we have no other answer, all right? I hope an answer will come, and I hope someone will develop it, which is to say they will figure out how to decrease the viral replication or otherwise achieve a higher PaO2. But if we don't have one, then we possibly may have to just, exacerbate this transition and cause some lung injury to get patients through, and hope that we can get them through on the other side. And I think that's kind of where we stand now. But I do think in managing these patients, we do have to consider, what are our priorities in these two separate patients, all right? And I will tell you that for me, in a type L patient, they seem to have very fragile lungs, all right? Very prone to injury. So my priority, is to keep the PEEP low, at the expense of the SpO2, which is at the expense of the PaO2. So right now we're saying shoot for 80. I do not know if that's right. I just believe that if your priority is to achieve a SAT of 92, there's nothing you can do except go much higher on the PEEP, all right? I do not believe in most patients you will be able to achieve a SAT of 92 or 94 that are that severe, that we've taken that far on high flow, that are that hypoxemic without jamming up your PEEP. So I am willing, my priority is to keep the PEEP low. And let's say they're SATing 70. Then I have to decide, what is my priority? Do I believe that it is more injurious for them to SAT 70, suggesting their PaO2, is pretty low, or is it more injurious to possibly increase the PEEP and cause lung injury? And these are difficult questions for which, currently I don't have an answer, and we're doing a case by, patient by patient basis, which makes for some difficult decision making. And in this, the priority, first, and this is sort of what Gattinoni suggests, is we are doing tidal volumes rather than 4 to 6, 6 to 8 in these high compliance lungs, because our priority would be to get more oxygen in and less to keep their volume under 6, because we believe that in these low lung weight, low elastance patients, that the tidal volume of 8 cc's doesn't significantly promote worse lung injury, all right? And whereas the priority over here for these ARDSNet patients, kind of ARDS patients, these are real ARDS, these are sort of COVID, I like to call them. So COVID patients, ARDS patients would be, part of this all is because most of this looks like it's a vascular issue. It doesn't seem like it's a alveolar recruitment issue, whereas these patients tend to have, high elastance, high lung weight, and this seems to be more of an alveolar recruitment issue, and you probably have many more alveoli destroyed. You have less alveoli, you have less sort of what we call baby lung, and so probably your tidal volumes, you want to keep them much lower, traditional kind of ARDSNet 4 to 6, potentially if you believe that in oxygen toxicity, whereas, here, I'm less concerned for oxygen toxicity because their PaO2s are super low. You might want to keep their SpO2 at 92%. I mean, this is sort of 88 to 92, which is sort of the ARDSNet. And so it's just about what your shifting priorities are, and if you say these patients, plateau, same thing, plateau less than 30. I mean, so what we're doing is we're generally on a type H patient that is pure type H. We are following ARDSNet, the sort of evidence-based work. For these patients, I don't think we have any evidence to go on. And right here, the transition is not immediate. All right, so they're not just one or the other. So we have to figure out when they're in here. Let's say we have a driving pressure of 15 or 16. SpO2 is still tanking, so they still, SpO2 is 83. And so clearly they're at FiO2 of 100%, they're kind of in the middle, some of the virus, whatever it's doing, their saturations are still showing evidence of active viral or complications of the active viral disease. Figuring out what to do with these patients is difficult, and it all has to do with our priorities. Just to quickly go over it, the last thing you'll have to do when thinking about priorities is you will have to sedate these patients at some point. So I just want to quickly go through, what are our sedation drugs. So you generally have opiates, fentanyl, Dilaudid, morphine, fentanyl, the big ones, fentanyl, Dilaudid, morphine. We have benzos. We have, ketamine. I'll talk about ketamine later, but ketamine, Precedex. We have antipsychotics, propofol. All right. So a lot of it is what our priorities are. So if we've decided on, one thing I've decided for my priority in these patients that are COVID patients as opposed to ARDS patients is that I do believe that desynchrony is probably harmful. So I am in a pandemic situation where we have tons of, we have hundreds of vented patients in New York. Again, we're not kind of getting them up and moving around as best we could because, of the contagion and so forth. I'm willing to sacrifice their sleep-wake cycles and possibly increase their delirium and decrease their mobility and to keep them well sedated, because it's terrible if they self-extubate, and that could, mean death for them. So I'm generally keeping them more sedated and trying to avoid any dysynchrony, and if they need to, we're paralyzing them. We're trying not to do it that long and limit, how much paralysis we're giving, because it can, again, the paralysis will make it so you don't have any vent synchrony. But to rob Peter, pay Paul, on the flip side, the patient is not triggering the vent, is at high risk of getting diaphragmatic weakness, and in general, they can cause, a neuromuscular weakness and myopathies. So it's, everything is a give or take, everything you do. So just to quickly go, if you're trying to decrease someone's breathing, for example, if I say, I want to sedate them, but really I just want to decrease their respiratory rate, then you want to do it with drugs that do it. So obviously Precedex and ketamine you would not use, because it doesn't really tend to decrease someone's respiratory drive. When you're saying I want to manipulate their own ventilator to, decrease their respiratory drive, you should pick, probably opiates are the best. Benzos will probably do it, propofol will tend to do it, but everything has a downside. To go with opiate, just to go quickly down the line, opiates tend to decrease respiratory rate. Morphine can cause decrease in blood pressure. Fentanyl tends to do that less, but predominantly these are heavily used to decrease respiratory rate and to decrease pain. All right, benzos, they do work very good if you run them at high doses. What's the downside? Well, Versed does tend to stay in tissues for a long time. So I usually don't use it in the ICU, not only because there's studies that it promotes delirium, which were generally IV pushes, but because if you're not having someone on a long ventilator run, then you don't necessarily want Versed to be stuck in their tissues, because it might be a while for you to get them off the vent, and it certainly can change their mental status, and they can have prolonged sort of mental changes. They can also build up tolerance, but we're using benzos in these patients partly because we're running out a lot of drugs, but they don't tend to cause a lot of hypotension, so we can avoid that and hopefully avoid the pressors, and they're long ventilator runs. So even if we run them high, stop it in 3 days, and they take another 3 days to come off, they're still probably not at a point where they could be weaned off the vent. I'm going to skip ketamine quickly. Precedex. Precedex tends to, the good thing about it is it doesn't tend to alter your consciousness, which is to say that people get sleepy, but it doesn't tend, if you can wake them up, they're usually able to talk to you like a normal person, whereas propofol is not. Propofol tends to alter your consciousness. So for ER doctors out there, if you've given propofol for sedation, sometimes people say very goofy things, going out of it, but Precedex will tend not to decrease your breathing. So, for me, I like Precedex more when you're approaching extubation, because you want to keep them, more awake. You want to be able to engage with them. You want to reanimate them. You don't want their consciousness to be screwed. It helps, there's some studies that show it helps for delirium, So this tends to be something, it will not knock someone out. You know, you can't just use Precedex and expect someone's going to be down on the vent. It just won't work. Propofol, what's good is you can, turn it off, and unless it's been running for a very long time, people can, tend to, wake up after that. So it's good if you're doing SVTs and so forth. The downside, of course, it alters your consciousness. It can cause hypotension if anyone has heart failure. It's a myocardial depressant, as can Precedex, can cause bradycardia and hypotension. So, Haldol we use heavily in fellowship, which I feel like people are slightly moving away from because there were some studies that showed it didn't really help for delirium, although it was hypoactive delirium. But generally at Maryland, we would try to get people on Haldol, and hopefully PO opiates. Sort of, if we could keep people that were trying to reanimate on that, it was kind of considered that's what we were go-to. Ketamine, I'm going to quickly talk about because it's slightly different, all right? And again, this is all about what your priorities are. If I want to keep someone breathing, which generally these COVID patients are not those patients because they're breathing on their own. If you look at their mental ventilator interaction, if you were to put them on a vent and just not sedate them at all, their respiratory rates go up to like the 50s, all right? Which is generally thought to be unsafe on vents. At least Gattinoni says try to keep the respiratory rate below 20. All right, so I'm not using as much ketamine on these patients as I certainly normally would, and ketamine hasn't found its necessarily ubiquitous place in the ICU anyway. And so I feel like a lot of these patients are getting a lot of opiates to drop the respiratory rate. But ketamine in general, I will just say lastly, at the end of this very long talk about mechanical ventilation, so I'm not talking about ketamine, is I don't see ketamine as sedation. All right, I think it's a misnomer, and it tends to make it so people use it inappropriately. All right, sedation generally, if you follow the American College of Anesthesiology, I think that's what it's called. It goes from mild, moderate, severe, or whatever, something to deep. All right, and this is all increasing sleepiness essentially, and decreasing response. Increasing sleepiness, decreasing response to stimuli, all right, until someone's fully anesthetized, all right, but ketamine does not necessarily cause sleepiness, all right, so anyone who's given it to kids to do, a procedure, their eyes are often open, and they just are completely gone, they are dissociated. What it is it essentially is a separation. It essentially separates your limbic and cortical systems, so people cannot cortically process sensory stimuli. So they receive sensory stimuli from the outside world, but it's probably received, but it is not processed. Thereby, one doesn't react to it necessarily with formed cortical reactions. All right, and really, I see ketamine. On a spectrum rather than a spectrum of sedation, as a spectrum of catatonia. All right, and they're actually using ketamine to study schizophrenia, and it seems to, in some ways, mirror the negative symptoms of schizophrenia. So essentially, you can use it at smaller doses, which are more pain doses. Again, probably to some extent, you are less able to cortically process the pain. And as you increase, you get 1 milligram per kilogram, it starts to get, pretty severe until you're fully dissociated, all right? Usually a bolus of 1 milligram will get you almost there, 1.5 milligrams per kilogram. Bolus will usually get you, dissociated until people are fully catatonic. And I don't know if someone is here. There could be there could be a lot of use for this in the ICU. Generally ketamine is thought to, decrease bronchospasm, in some senses neuroprotective, used for seizures, is used to treat PTSD. I don't know if in some sense cause PTSD, has good hemodynamic profile, and potentially could increase cardiac output. So, all this means that it could be a good drug, and also catatonic patients are much easier to deal with in some sense for us because they're not moving quickly, they're still able to talk, in some sense they're still awake. I just am not entirely sure what the patient experience is here. And nor do I know to keep someone fully sedated, for example. It would be a great idea to keep someone fully sedated in ARDS or these COVID patients if they're paralyzed and you could only use one agent. Imagine if you could just run ketamine, which seems to have all these protective qualities, except to really get a fully dissociated dose, you'd have to run it pretty high, like 7 milligrams per kilogram per hour. And this really are no studies to suggest that's safe. So we use ketamine kind of at low adjunct doses, but it's not, I think, we're not primarily using it in the ICU, but if you want to keep people breathing, I do think there probably is a large place for this, and I know a lot of people, very, very smart people that are using it, at doses, 2 milligrams per kilogram, which kind of lead to sub-dissociative, doses. And I think more research needs to be done on it, because if the patient experience was not bad and it was safe, it would be highly useful. All right, so that was a lot to cover today, and it was very quickly, and we'll try to refine it, but we're in a time of rapid movements, and we just got to get this stuff out there for everyone who, in these next coming days and weeks, and hopefully not months, will be taking care of COVID-19 patients and might be caring for people on ventilators, even though they're not typically used to it. So again, we went through the naming systems, why they're named certain ways, and just in order. Make sure you know them. You got to know the normal scalars. You got to understand what everything's telling, what the waveforms are telling you about lung mechanics and what you're doing when you're adjusting things. When you eventually get to the point where you're working towards extubation, you got to understand the patient-ventilator interaction once they're not super sedated or paralyzed, and then you got to think about what your priorities are, and manipulate either our vent or the patient's vent, accordingly. And all those priorities will change as people move through their disease states, and will be hotly debated in general. But that's what we went through today. I hope this helped, and hopefully it can be useful for at least someone. All right.